Welcome to the deep dive. Today we're taking you into a really fascinating medical module. It covers pediatric neurological and sensory disorders.
Right, and it's a huge topic.
It is. Our mission here is to explore the incredibly complex biological wiring of a child's developing nervous system.
Yeah.
We're going to look at what happens when there are glitches in that system and how medical science steps in to map, manage, or sometimes physically reroute those pathways.
It's a really profound area of medicine. We'll be connecting the dots between highly visible outward symptoms that you might actually recognize and the entirely invisible neurological mechanics driving them beneath the surface.
Yeah, the stuff you can't see.
Exactly. Today is really about understanding the why behind these conditions, taking you past the clinical definitions and into the actual mechanics of the human body.
I always marvel at how the brain and the spinal cord form this ultimate central control system. And what's really compelling about the material today is how the earliest clues to major life-altering neurological puzzles are often hidden in the absolute simplest things.
The things you'd almost overlook.
Right. We're talking about a baby's basic physical reflexes, the literal shape of their eyes, or even just a tiny, seemingly harmless dimple on their lower back.
Huh.
Okay, let's unpack this. When doctors are trying to assess the wiring of a newborn, how do they even begin to read a system they can't directly see? Right. Because an infant can't tell you where it hurts. They can't follow complex commands like, squeeze my fingers or follow this light. So if a baby is missing primitive reflexes, like that incredibly strong grasp reflex when you put a finger in their palm.
Or the Babinski reflex.
Yes, the Babinski, where their toes fan outward when you stroke the sole of their foot. If that is absent, that's a direct red flag pointing to a central nervous system problem.
That is the pivotal switch right there. And timing is everything with these readouts. If you look at that Babinski reflex, it's completely normal for a newborn.
They all do it.
Exactly. But if that exact same reflex persists past 12 months of age, it flips from being acute baby behavior to potentially indicating a structural problem in the brain's frontal lobe.
Because it's supposed to stop.
Right, the central nervous system is supposed to mature and suppress that reflex. When it doesn't, you know the signal is getting lost somewhere.
And it gets even more granular when you look at deep tendon reflexes. Say a doctor taps a child's knee. If they get a decreased sluggish response, that points to a peripheral nervous system issue.
Because the signal isn't making it out.
Exactly. The electrical signal simply isn't reaching the muscle through the peripheral wires. But conversely, if there's an exaggerated response, like the leg kicking out violently and briskly, that points right back to the central nervous system.
The brain isn't properly regulating and dampening the physical signal.
Right. It's like a thermostat that's broken.
Which leads us directly into what happens when the very formation of that central command center goes off track during early development. The module focuses heavily on neural tube defects, with spina bifida being the most common.
And the crucial detail linking all of this together is a maternal deficiency in folic acid.
It's amazing how specific that is, and the timeline here is just staggering. The closure of the neural tube happens around the 1-month mark of pregnancy.
Which is usually before a woman even realizes she's pregnant.
Exactly.
Which completely explains the universal recommendation for all women of childbearing age to take folic acid. Not just those actively trying to conceive, but everyone. Because when that neural tube fails to close properly, spina bifida presents on this massive spectrum of severity.
It's a huge spectrum.
And the most deceptive part of this spectrum is spina bifida occulta, which literally translates to hidden.
Right, because the spinal cord and the nerves themselves are completely normal in occulta. It's just a section of the spinal vertebrae that is malformed. Because everything vital is intact and tucked away, there is no visible sac on the back.
It's practically invisible.
It really is.
Unless you know exactly what to look for. You might just see a deep sacral dimple right above the buttocks, a little tuft of hair, or hemangioma, which is a cluster of blood vessels on the lower back. So many people walk around their entire lives completely asymptomatic, never knowing they have spina bifida occulta.
Yeah, it's usually only discovered by pure accident, like if they happen to get an MRI for a totally unrelated back injury years later.
Wow. But moving up the severity scale, you encounter a meningocele.
Right. This is where the membrane surrounding the spinal cord actually bulges out, creating a visible sac on the back.
But the cord itself is still inside.
Exactly. It doesn't always cause disability, and surgeons can often repair it pretty effectively. But the clinical picture shifts drastically with the most severe form, which is myelomeningocele.
Yeah, with myelomeningocele, a section of the spinal cord itself and the associated nerves are literally exposed on the outside of the baby's body.
It's a very intense situation.
This causes partial or complete paralysis below the location of the opening, alongside severe complications like a lack of bowel and bladder control. And a sobering reality here is that while neurosurgeons can operate to close that opening and protect the tissue, the surgery doesn't magically cure the paralysis.
The neurological deficit is permanent.
Right, which makes the immediate neonatal care for these infants incredibly high stakes.
Imagine you are in the delivery room. The moment a baby with myelomeningocele is born, the medical team have to act instantly to protect that exposed neural tissue. They cover the defect with a sterile dressing soaked in warm saline.
Specifically to keep the delicate nerves from drying out and dying.
Exactly.
The physical logistics are intense. You can't just lay the baby down normally. They have to be positioned prone flat on their stomach, with their hips flexed up underneath them, resting on an open diaper.
You're trying to keep the area completely sterile and isolated from any biological waste until pediatric neurosurgery can intervene.
Beyond spina bifida, the clinical data also covers other severe neural tube defects. You have encephalocele, where a portion of the brain actually protrudes through a structural opening in the skull, usually at the back of the head or right between the forehead and nose.
And then there's an encephaly. That's where the neural tube defect is so catastrophic that the majority of the brain and skull simply never develop.
It's almost universally fatal, resulting in stillbirth or death very shortly after delivery. Though there was one deeply touching exception mentioned in the source material, a little boy named Jackson who actually lived to be 5 years old. He built this massive social media following, despite missing the top portion of his brain and skull.
It's incredible. But if we connect this back to the bigger picture of preventative public health, there is a massive success story hiding in these numbers.
The folic acid fortification.
Yes. Since the United States began mandating the fortification of everyday grains with folic acid, the rate of anencephaly has plummeted by 28%.
That's huge.
It's down to about 3 in every 10,000 pregnancies. It's a striking testament to how a single minor dietary intervention on a national scale can drastically alter human fetal neurological development.
Okay, here's where it gets really interesting. Because sometimes the underlying issue isn't a missing piece of the brain or an exposed nerve, but rather a mechanical problem with the physical space the brain has to exist in.
The structural defect.
Exactly. Let's look at the Chiari malformation.
Think of the skull as a rigid container. In a Chiari malformation, the bony space at the very lower part of that container is simply too small for its contents.
It's cramped.
Right, and because the space is cramped, it physically forces the cerebellum, which is the part of the brain controlling balance, and the brainstem downward, pushing them through the bottom of the skull and into the spinal column.
And the severity dictates the symptoms. Type 1 often presents with 0 symptoms and, again, is found completely by accident.
But type 2,
which is known as Arnold-Chiari malformation.
Yes, Arnold-Chiari. That involves a significant downward herniation. And the clinical link here is crucial. Type 2 is heavily associated with that severe form of spina bifida we just discussed, myelomeningocele.
That downward physical pressure acts like a cork in a bottle. It blocks the normal vital flow of cerebrospinal fluid.
And children with this suffer from severe dizziness, muscle weakness, vision problems, and debilitating headaches. In many cases, they have to be strictly medically restricted from playing any contact sports.
Because their brainstem is essentially sitting exposed in the spinal column.
Exactly, making them incredibly vulnerable to devastating head trauma.
Another structural mystery that just defies logic is agenesis of the corpus callosum.
This one is fascinating.
Let's use a visual here for you listening. Think of the brain's 2 hemispheres as 2 separate, massive land masses. The corpus callosum is the colossal structural bridge that connects them. It contains millions of nerve fibers that allow the left and right sides to communicate.
In agenesis, that bridge is either partially or completely missing.
Right. And what makes this condition so baffling to neurologists is the clinical presentation. You would assume missing the main communication highway of the brain would be catastrophic.
You'd think so. But the symptoms range from severe cognitive delays to absolutely nothing at all.
Nothing.
You can have a person whose 2 brain hemispheres are physically disconnected and they exhibit 0 symptoms, living completely normal, unnoticed lives.
It really challenges our basic assumptions about how the brain compensates.
It really does.
Now, contrasting with a missing internal structure, you have microcephaly. This is where the head circumference is more than 2 standard deviations below the average for the child's age and sex.
The brain simply stops growing.
Right. And the medical literature traces this back to severe viral exposures during pregnancy. Things like the Zika virus, cytomegalovirus or CMV, and rubella. The brain's development is arrested, leading to significant cognitive delays.
We have to clearly distinguish that viral arrest of growth from a mechanical restriction, though, which is craniosynostosis.
Good point.
A healthy infant's skull isn't a solid bone. It's made of distinct plates with flexible, fibrous sutures between them. This design is specifically to accommodate the explosive brain growth that happens in infancy.
The brain needs room to expand.
Exactly.
Yeah.
But in craniosynostosis, those sutures fuse prematurely. The healthy brain is trying to expand, but the rigid skull won't yield, resulting in highly abnormal head shapes. Neurosurgeons literally have to go in and manually cut new suture lines to give the growing brain room to expand.
But what happens when the skull has plenty of room? But there's a severe plumbing issue deep inside the brain.
That brings us to hydrocephalus.
Cerebrospinal fluid, or CSF, is constantly produced. But in this condition, it collects abnormally, ballooning the ventricles inside the brain. And the symptoms in an infant are striking. Because the fluid is trapped and the baby's skull hasn't fully fused yet, the building pressure physically forces the head to grow at an alarming rate.
The signs of that internal pressure are very distinct. You'll see a visibly bulging fontanelle, which is the soft spot on top of the head. And because the stretching of the meninges is incredibly painful, the infant exhibits a very specific, high-pitched, shrill cry.
It's unmistakable.
But perhaps the most visually arresting symptom is what clinicians call sunsetting eyes.
Right, think about the mechanics of that. The fluid pressure inside the skull is so immense that it physically pushes down on the optic nerves and the structures controlling the eyes.
And it forces the eyes downward.
So the irises literally look like little suns setting below the lower eyelids. If this isn't treated rapidly, that rising intracranial pressure leads to a slowing heart rate, apnea, and eventually death.
The modern medical treatment for this is just a brilliant piece of biomedical engineering. The ventriculoperitoneal, or VP, shunt.
How did that work?
A neurosurgeon places a flexible catheter directly into one of those flooded, enlarged ventricles inside the brain. That tube is attached to a one-way pressure valve, and then the rest of the tubing is tunneled entirely under the skin.
Down the side of the head?
Down the neck, across the chest, and directly into the peritoneal cavity of the abdomen.
So the excess brain fluid literally drains into the belly.
Yeah, where the body's bloodstream just harmlessly reabsorbs it like a sponge. It's a mechanical bypass.
That's incredible. But the postoperative care requires intense vigilance. Parents are trained to watch for signs of a blockage, like sudden vomiting, lethargy, or severe headaches.
They also have to watch if the shunt is draining too aggressively, which drops the pressure too fast and causes intense dizziness.
And you have to account for the fact that the child is going to grow, but the plastic tubing won't.
Right, surgeons actually leave an extra coil of tubing down in the abdomen to unspool as the child gets taller. Even with that, these patients typically require multiple surgical revisions up until they reach about 80% of their adult height.
There's a deeply empathetic clinical detail here regarding post-op care. Pain medication for these babies isn't just about comfort. It's a vital neurological intervention.
Because crying physically increases intracranial pressure.
Exactly. The absolute last thing you want is a baby with a fresh brain shunt screaming in pain, actively spiking the pressure inside their fragile skull.
It's a delicate, high-stakes balancing act. So we've covered the structural blueprints and the plumbing. Let's shift to the electrical system.
The electrical storms.
Yes. What happens when you have an abnormal electrical storm in the brain, which is a seizure?
We generally classify these into generalized and partial seizures. Generalized seizures involve the entire electrical grid of the brain. The one most people recognize is the tonic-clonic seizure.
Also known as grand mal.
Right. Tonic means absolute muscle rigidity, and clonic refers to the violent rhythmic jerking. The child loses consciousness, falls, and may lose bladder control.
But it's critical to understand that not all seizures look like violent shaping. And this is a massive point for anyone listening who works with children. Consider the absence seizure.
These are so easy to miss.
In this state, the child just completely loses awareness for a few seconds. They might simply stare off into space, smack their lips slightly, or blink rapidly.
Think about the last time you zoned out during a boring meeting. To an outside observer, an absent seizure looks exactly like that, a kid just daydreaming.
And because a child might have hundreds of these tiny electrical misfires a day, they are constantly missing chunks of instruction.
The data explicitly notes how often these children are unfairly punished by teachers who think they are just being defiant or ignoring them, when in reality they are experiencing an involuntary, unconscious neurological reboot.
It completely changes how you view childhood behavior.
Another category is febrile seizures, which are specific to kids aged 3 months to 5 years.
These aren't caused by epilepsy, though. They are triggered by a rapid, sudden spike in body temperature, usually from a routine viral infection.
They are utterly terrifying for a parent to witness.
Absolutely terrifying. But clinically, they are usually very brief, they do not cause structural brain injury, and they don't mean the child will develop epilepsy later.
Regardless of what kind of seizure is happening, the physical interventions are universal. First, you time the seizure. But you have to be careful to stop timing when the active seizing stops, excluding the post-ictal period.
That's the phase right after the electrical storm breaks.
Right, where the child is deeply drowsy, confused, and just needs to sleep. You roll them on their side to keep their airway clear, you absolutely do not restrain them, and you never put anything in their mouth.
And for kids with known seizure disorders, caregivers use strict at-home protocols. If a seizure hits the 2-minute mark, parents are trained to administer a pre-filled rectal diazepam gel.
Which acts essentially as a chemical circuit breaker to stop the electrical storm.
Exactly. But if that seizure crosses the 5-minute mark, it shifts to a medical emergency, and you call 911.
Now, the brain's electrical activity also heavily dictates sleep and involuntary movements. The clinical guidelines draw a sharp line between common sleep disturbances.
Like nightmares versus night terrors.
Yeah. Nightmares happen during REM sleep, usually early in the morning. The child wakes up fully, and they remember the scary dream. Night terrors are totally different.
They occur early in the night during deep non-REM sleep. The child might sit up and scream in absolute terror, but their brain isn't awake.
Parents can't comfort them.
No, and the next morning, the child has absolutely zero memory of the event.
Along with sleep, we see electrical glitches in movement, like tics. You have motor tics, blinking, grimacing, neck jerking, and vocal tics.
And here is a diagnostic trap. Vocal tics like constant sniffing or clearing the throat are incredibly frequently misdiagnosed as simple seasonal allergies.
Because people assume any persistent tic is Tourette's syndrome. But the diagnostic criteria for Tourette's is incredibly strict. A child must have both motor and vocal tics. They must be continuously present for over a year, and the onset has to occur before age 18.
In reality, most children experience transient tics that they simply outgrow as their nervous system matures.
Okay, so we've mapped the structure, the plumbing, and the electricity. Let's look at what happens when an outside invader breaches the system. Meningitis.
Meningitis is an infection of the meninges, the fragile protective coverings of the brain and spinal cord. While it can be viral or fungal, bacterial meningitis is a zero-tolerance, life-threatening medical emergency.
The clinical directive here is unbending. If an infant is acutely ill, lethargic, and has a fever, they must be treated as having meningitis until a doctor explicitly proves otherwise.
They perform a lumbar puncture to test the spinal fluid. But right at the bedside, doctors use 2 fascinating mechanical lever tests to check for inflamed meninges.
Kernick's sign and Brudzinski's sign.
Yes. With Kernick's sign, the patient lies flat. The doctor flexes the child's hip up to a 90-degree angle and then tries to straighten the knee. If the meninges are inflamed, this mechanical stretch causes severe pain.
And Brudzinski's sign is even more involuntary. The doctor physically flexes the patient's neck, tucking their chin to their chest. If the meninges are insected, the sheer pain of that stretch causes the patient's knees and hips to involuntarily pull upward defensively.
Moving from acute infections to chronic motor disorders, we look at conditions resulting from damage or genetics, cerebral palsy or CP.
CP is an umbrella term for brain damage that occurs before, during, or shortly after birth, often from oxygen deprivation, trauma, or an infection like the meningitis we just discussed.
70% of these cases are the spastic type, characterized by stiff limbs and a scissor-like walking gait.
Because the brain damage is permanent, there is no cure. The medical focus is entirely on aggressive physical therapy, using muscle relaxants, and frequently injecting Botox into the muscles to relieve that relentless spasticity.
While CP is caused by an injury to the brain, spinal muscular atrophy, or SMA, is a tragic genetic error inside the spinal cord itself.
It degrades the anterior horn cells.
Exactly, resulting in severe weakness and wasting of voluntary muscles. It is the most common recessive genetic disorder that is lethal in children.
The reality of SMA type 1 is profound. The degradation begins in utero or early infancy. The baby struggles to suck and swallow, creating a high risk of aspirating fluid into their lungs.
But the ultimate failure point is their respiratory muscles. Despite intense supportive care, SMA type 1 is usually fatal by age 3, entirely due to the failure of the muscles required to breathe.
Which is exactly why protective and preventative measures for a healthy nervous system are paramount. This brings us to the final area of the module, head injuries.
Preventing trauma with helmets and proper car seats is the ultimate first line of defense.
But when a child does sustain an injury, reading the signs accurately is a matter of life and death. A minor concussion might cause temporary confusion or vomiting, but clinicians are trained to watch like hawks for late findings.
These are the ominous symptoms that appear when a severe head injury is actively worsening, often seen when a child wasn't found immediately after a fall or accident.
These late findings tell you the brainstem is under critical pressure. You'll see a dangerously slowing heart rate. You'll see sluggish pupils that don't constrict normally when a light is shined in them.
But the most alarming sign is highly abnormal, rigid body posturing, known clinically as decerebrate or decorticate posturing.
The child's arms might rigidly extend, with the wrists violently flexed outward.
It is a physical manifestation of a brain rapidly sliding toward a coma.
So what does this all mean for you listening? When you understand these conditions, from the brilliant plumbing mechanics of a VP shunt to recognizing that a kid staring blankly at the chalkboard might be having an absence seizure, you gain a profound appreciation for the human nervous system.
It is simultaneously incredibly fragile, yet astonishingly intricate and adaptable.
I couldn't agree more.
I want to leave you with one final thought, building on the sheer adaptability we've discussed. We talked about how massive structural deficits, like missing the entire corpus callosum, can sometimes result in zero symptoms.
Which is still wild to me.
It raises a fascinating question about neuroplasticity. If a developing child's brain can literally rewire its entire communication network around a missing structural bridge without missing a beat, what untapped regenerative abilities, what dormant pathways are simply lying completely unused inside our own adult brains right now?